شكرا جزيلا دكتور محمد. أنا يعني سعيد جدا أن أنا بشارك معاكم الحقيقة. وأنا بشكر طبعا اللجنة المنظمة للمؤتمر، وكمان بشكر شركة فايزر على دعوتهم ليا لإلقاء المحاضرة. أنا مش هطول عليكم لأن أنا عارف أن أنا يعني بتاع آخر الليل ده ما بيبقاش مسموع، إنما أنا يعني حاول أتكلم على حاجة جديدة دلوقتي which is the emerging small molecule biologics. In fact, I think it is a very good option now to have another choice other than the ordinary biologics we know in the last few years. This is just introductory case. A 34-year-old lady well diagnosed as ulcerative colitis 3 years ago was on 5 aminosalicylates, developed recurrent relapses while on 5 aminosalicylate. The last one was 10 months ago with 8 to 10 motions, mostly 5 to 6 of them were bloody. The patient received courses of prednisolone, 60 mg, with the last course was 6 months ago. The patient gave a partial response to full dose of steroids with failure to withdraw steroids below 10 milligram. The fecal calprotectin was 899 and the drop while on corticosteroids to 400. Her endoscopic Mayo score was 3. This was her endoscopic Mayo score. The patient was given after that infliximab as anti-tumor necrosis factor on a dose of 5 milligrams per kg, induction at 0, 2, and 6 weeks, IVI, then every 8 weeks maintenance, plus azathioprine 150 milligram per day. There was initial improvement of the symptoms occurred after the third induction dose and the first maintenance, with regression of the endoscopic Mayo score from 3 to 2. This was her Mayo score after an induction and the first maintenance of infliximab. The patient started to complain of recurrence of blood-tinged diarrhea 4 to 5 times per day before the second maintenance dose. The trough level of the infliximab was normal with no circulatory antibodies to infliximab. This means that there is a failure of infliximab. The decision of holding anti-tumor factor was taken and the patient was shifted to tofacitinib, Xeljanz of Pfizer, at a dose of 10 milligrams per oral BID. After 2 months of treatment, the patient showed improvement of her symptoms, 1 to 2 motions per day, with no blood, with drop of the fecal calprotectin to 150 and CRP below 7. Her endoscopic Mayo score after 2 months was 1. The patient was kept on maintenance dose of 5 milligram BID and doing well up till now. This was the final Mayo score after 2 months of induction with tofacitinib. This leads us to talk about the small molecule biologics. Our talk today about tofacitinib, Xeljanz, Pfizer, which is an orally administered genus kinase inhibitor. This is the first oral biologic we have. And actually, it is very interesting to have oral biologic. It's feasible in administration, less costly according to the price, and as well as it less exposure to the hospitalization and the time consumption by the patient. In fact, it is administered to control the severe or moderate ulcerative colitis, whether naive or biofailure. In fact, it is approved first for biofailure, and then it can be used for the naive patient with moderate to severe ulcerative colitis. It's working through affection and blockage of the genus kinase STAT pathway, and through stoppage of the genus kinase receptor. As you see here, there is tofacitinib working at the JAK1 and JAK3 receptors that block the JAK-STAT pathway, as we will see. The JAK-STAT pathway is the genus kinase signal transducer activator of transcription, and this is the diagram showing the pro-inflammatory cytokine attached to the JAK receptor, and this JAK receptor lead to phosphorylation of STAT, which is a signal transducer and activation of transcription. And this phosphorylated STAT dimerization and the translocation occur inside the nucleus to do DNA transcription with subsequent production of cytokines, interleukins, and tumor necrosis factor, leading to inflammation and occurrence of IBD. The JAK STAT pathway inhibitors working at this site inhibit the JAK phosphorylation and prevent phosphorylation of STAT, dimerization, and subsequent translocation of STAT inside the nucleus. These are the JAK inhibitors developed in treatment of IBD. As you see here, tofacitinib is approved well for ulcerative colitis, phase 3, but it was discontinued for CD, Crohn's disease, because of less effect. Others now is going, the most phase 2 now is upadacitinib, which will be approved for Crohn's disease, and filgotinib is phase 3 for both Crohn's disease and ulcerative colitis. This is what's called OCTAV study, OCTAV 1 and OCTAV 2. This is the phase 3 of the study. They compared the ulcerative colitis patient, moderate to severe, induction with 10 milligram BID versus placebo. And they found in the OCTAV 1 that 59.9% had clinical response at week 8 versus 32.8 for placebo, and the clinical remission was 18.5 versus 8.2, and mucosal healing 31% versus 15%. For the OCTAV 2, they have 429 patients of ulcerative colitis on 10 milligram BID induction. They have clinical response in 55% versus 28%, and they have mucosal healing almost 30% versus 11%. This is for induction, and they found that for the adverse effect, mostly was infection versus placebo, 111 patient versus 19. For tuberculosis, the same as placebo. Opportunistic infection a little bit higher for tofacitinib versus placebo. For a cardiovascular event, it's more in tofacitinib versus placebo. In OCTAV 1 and 2, phase 3 for maintenance, they tried 5 milligram BID for patients versus placebo, and 10 milligram BID versus placebo. They found that the 5 milligram maintenance is approved or well to maintain mucosal healing up to the week of 52, and there is no much difference in the mucosal healing between 5 milligram and 10 milligram for maintenance in week 52, 45 versus 37, but they recommend that you have to shift from 10 milligram BID after 2 months, not more than 16 weeks, in order to minimize the thromboembolic effect that may have a side effect with tofacitinib. And this is diagram showing us OCTAV 1 and OCTAV 2, the number of patients versus placebo, and the effect markedly is tofacitinib versus placebo. For the treatment screening, the same as those with any biologic, but we add on the ordinary preparation, hepatitis B and hepatitis C, and as well as tuberculosis, and screening for infections, as well as screening for cardiovascular diseases. We have to stress on immunizations and the history of herpes zoster, which is called shingles vaccination, and as well as history of thromboembolic manifestation before we start tofacitinib. For this is the OCTAV, and we see here in OCTAV 1 almost 600 patients, and OCTAV 2 550 patients, and they achieve remission versus placebo 18 versus 8 and 17 versus 4. The contraindication of tofacitinib, it is well known to have some increase in the thromboembolic manifestations. And so we don't give tofacitinib to those with thromboembolic disease and with history of pulmonary embolism or deep venous thrombosis, because this may be aggravated with tofacitinib. Those patients with hypercholesterolemia, also you have to control the lipid profile before you give tofacitinib. Also, the females with oral contraceptive pills or tendency to thrombosis and hypercoagulable state shouldn't be given tofacitinib. The use and dose for treating adults with moderate to severe ulcerative colitis who have failed or intolerant to anti-tumor necrosis factor, we use tofacitinib. Dosing, in fact, they recommend several doses, but the Octave 1 and Octave 2 recommended 10 milligram for the induction BID for 2 months, then shifted to 5 milligram BID as a maintenance. But some authors recommend 5 milligram twice daily from the start and keep the other dose for those who are not controlled on 5 milligram BID in induction. You have to use 10 milligram. This is to minimize the risk of thromboembolic manifestation. As we just said, the most important adverse events are herpes zoster infection and thromboembolism. Tofacitinib is associated with higher rate of herpes zoster infection, particularly for patients receiving higher maintenance dose and for those who are immunocompromised or having other immune suppressant medication. There was a study, they studied 592 patients with ulcerative colitis. The incidence rate of herpes zoster was higher for patients on maintenance therapy with tofacitinib 10 milligram. But it is less for those patients on 5 milligram twice daily. So they recommend to shift maximum after 16 weeks of tofacitinib induction to 5 milligram twice daily to minimize these side effects. The FDA is alerting the public that preliminary results for a safety clinical trial shows an increased risk of serious heart-related problem and cancer with Xeljanz compared with tumor necrosis factor inhibitors. However, they didn't find that it is contraindicating the use of the drugs except for those patients having history of thromboembolic manifestation. Patients treated with tofacitinib are at increased risk of developing serious infection, but they found that it is same like those with anti-tumor necrosis factor. Serious infection develop, interrupt tofacitinib until the infection is controlled, then you can resume your infection again, your treatment again. Reported infections include active tuberculosis, like those with anti-tumor necrosis factor, invasive fungal infection, and bacterial and viral infection, including herpes zoster, as just we said. Everything is the same as other biologics, but malignancies here are Epstein-Barr virus associated with lymphoproliferative disorder is more common with tofacitinib. Lymphoma, they found that some cases with lymphoma occurred with tofacitinib treatment. The author of this paper in 2020, he highly recommended that tofacitinib is superior to placebo for induction of clinical and endoscopic remission at 52 weeks in participants with moderate to severe ulcerative colitis who had a clinical response after 8 weeks of induction of treatment with tofacitinib 10 milligram or placebo, the maintenance dose of 5 milligram BID. The optimal dose of tofacitinib for maintenance therapy is unknown. High certainty evidence suggests that there is no increased risk of arterial thromboembolism with tofacitinib compared to placebo. Further studies are required to look at long-term effectiveness and safety of using tofacitinib and other oral JAK inhibitor as maintenance therapy in participants with moderate to severe ulcerative colitis. And thank you for listening.
شكرا يا بيه، ربنا يخليك. يعني محاضرة رائعة طبعا كعهدنا بحضرتك وبمحاضرات حضرتك. طبعا يعني لو في أي أسئلة يا جماعة الدكتور يعني خالد بيه. طيب يعني خلاص يا دكتور خالد، هو مفيش حد عنده يعني أي كومنتس أو أي أسئلة. احنا يعني بنشكر حضرتك جدا على البارتيسيبيشن بتاعك الاكتف في المؤتمر بتاعنا، ووجودك دايما معانا، وهوبفully ان شاء الله باذن الله ان حضرتك تبقى متواجد معانا ان بيرسون. وانا عارف ان حضرتك انت هتسيبنا دلوقتي ولسه عندك محاضره ثانيه في الجلسه الباراليل اللي هي برضه مودريتد بالدكتور معتز، اللي هو برضه طبعا يعني زميلنا في عين شمس. وانت حضرتك عارف كويس جدا طبعا ان احنا بنعتبر ان يعني عين شمس هي يعني شريك في المؤتمر بتاعنا، زي ما احنا ان شاء الله باذن الله في شهر 6 نكون مع حضرتك ومع الدكتور طارق والدكتور سامح بيه والدكتور احمد وكل المجموعه العظيمه بتاعتكم في عين شمس. شكرا لحضرتك يا بيه، ربنا يخليك، ويعني نشوف حضرتك على خير قريبا باذن الله. شكرا دكتور
خالد جدا، وبشكركم جدا على الدعوه، والف الف الف مبروك نجاح المؤتمر ان شاء الله.
شكرا يا بيه، ربنا يخليك.
شكرا جزيلا.